The next topic is gutted psoriasis. This type of psoriasis is more common in children and in adolescents, and it may be precipitated by a streptococcal infection, as we have discussed. So, someone with a history of a streptococcal infection about 2 to 4 weeks ago and present to you with teardrop papules that are found on the trunk and limbs. So, the gutted psoriasis, it mainly occurs on the trunk, and it is usually precipitated by an upper respiratory tract infection. Most of the cases of gutted psoriasis, they resolve spontaneously within 2 to 3 months. So usually no treatment is required in gutted psoriasis. And there is no evidence to support the use of antibiotics to eradicate streptococcal infection. Topical agents can be used in the management of gutted psoriasis as well if it persists beyond 2 to 3 months, or if the person is distressed about his symptoms. Then topical agents such as vitamin D analogs or topical steroids or coal tar, they can be used. Ultraviolet phototherapy can also be used. And if there is recurrent episode, then tonsillectomy may be necessary. So a child with recurrent episodes of gutted psoriasis, tonsillectomy may be a good option. You can see in the diagram that this psoriasis is different from plaque psoriasis. In plaque psoriasis, there were larger areas of plaques, but here there are papules, teardrop papules, or you can say that the size of the plaques is small. That's why they are known as teardrop papules. All these lesions, they are very small, just like teardrops. So this is what gutted psoriasis is and its management. Now, a short summary of psoriasis. Presentation is well demarcated red or pink elevated plaque. So the first thing is there's a demarcated red plaque with overlying white or silvery scales on extensor surfaces of the body. These are the 3 points that you need to remember to make a diagnosis of psoriasis. Well demarcated plaques with overlying silvery scales on extensor surfaces of the body and scalp, your diagnosis will be psoriasis. Auspit signs is positive. What is auspit signs? Scraping of the lesions causes pinpoint bleeding. This is known as auspit signs. The disease is chronic and relapsing. Summary of the management include steroids, vitamin D analogs, coal tar, and phototherapy as well. And some points about psoriatic arthritis. So we already know that the type of arthritis, psoriatic arthritis, is a seronegative uh, arthritis because RA factor is negative. Distal interphalangeal joints, they are more commonly involved. It is a polyarthritis, a symmetrical polyarthritis. Both sides of the body are affected. Treatment is NSAID for the pain, and DMRADs such as methotrexate or sulfasalazine can also be used in the management of psoriatic arthritis. A comparison between eczema, psoriasis, and seborrheic arthritis. In eczema, a red rash is present on flexor surfaces of the body, and it is more common in children. It is less common beyond 10 years of age, because most of the cases of eczema, they resolve when the child reaches 10 years of age. Psoriasis, it is common in adults and in older people. Elevated red rash with overlying silvery scales on extensor surfaces of the body. And eczema is on body creases or body folds. Similarly, seborrheic dermatitis is because it is a dermatitis of sebum rich areas, so there will be greasy areas with fine scaling. Found on face, scalp, and chest. In psoriasis, there will be strong family history. Similarly, in eczema, there will be a family history or personal history of atopy as well. And also, eczema is triggered by environmental factors. Auspit signs and Koebner's reaction will be positive in case of psoriasis. Auspit sign is pinpoint bleeding when the lesions are scrapped, and Koebner's reaction is new lesions appear at the site of injury. So whenever there is an injury, usually no new lesions appear at the site of injury. While seborrheic dermatitis is an inflammatory reaction to a yeast. Management of eczema is emollients and steroids. Management of psoriasis is corticosteroid, vitamin D analogs, and TAR preparation. And management of seborrheic dermatitis is antifungal medications. The next topic is urticaria. What is urticaria? Urticaria, you need to remember 2 points to make a diagnosis of urticaria. That is wheal and flare reaction. What is wheals? A central itchy white papule or plaque surrounded by erythema. You can see in this diagram that there is a central white papule and there is surrounding red area. So a central itchy white papule with surrounding erythema, you will suspect urticaria. And the second point that is important, that urticaria come within a few minutes or hours and then also resolve spontaneously. Here today and gone tomorrow. So it come and go within a few minutes or hours. There are two types of urticaria. One is acute urticaria and the second is chronic urticaria. If urticaria is present for less than 6 weeks, then it is acute urticaria. If it's present for more than 6 weeks, then it will be chronic urticaria. The causes of urticaria, which drugs that can lead to urticaria, they include aspirin and opiates. Aspirin and opiates, they may elicit the release of histamine from mast cells and can lead to urticaria. So urticaria is basically type 1 hypersensitivity reaction. Type 1 hypersensitivity reaction involve the release of histamines from mast cells or basophils, which result in this wheal and flare reaction. Urticaria can be caused by aspirin, it can be caused by opiates, it can be caused by overheating, it can be caused by stress, it can be caused by alcohol, it can be caused by caffeine intake. So remember these risk factors for urticaria, that drugs, overheating, alcohol, and caffeine, they all can lead to urticaria. Treatment is antihistamines, non-sedating antihistamines such as cetirizine and loratadine. And in pregnancy, because there is no data about the safety of these cetirizine and loratadine, so that's why in pregnancy we prefer to give sedating antihistamines such as chlorpheniramine because they are perfectly safe to use in pregnancy. There is one other term that is known as physical urticaria and contact urticaria. So how you are going to differentiate between contact urticaria and contact allergic dermatitis? As I told you that urticaria is a type 1 sensitivity reaction. So it develops within minutes, while contact dermatitis is a type 4 sensitivity reaction. So contact dermatitis will take hours to days to develop. So this is the difference between contact urticaria and contact dermatitis. If someone develop rash immediately after when he come in contact with food or insect bite or even nickel, then it will be contact urticaria. And if the redness or rash develop hours or days after contact with the offending agent, then it will be contact dermatitis. So contact urticaria should be distinguished from contact dermatitis, where a dermatitis reaction develops hours to days after contact with the offending agent, because it's a type 4 hypersensitivity reaction. So this is the basic difference between contact dermatitis and contact urticaria. So normally how a question about urticaria will be asked in Plab 1 exam. Remember these points to suspect urticaria. Eruption of itchy rash after upper respiratory tract infection or after stress, for example, playing football, exercise induced urticaria, or after taking aspirin or opiates, or soon after an insect bite, we will think urticaria. And the treatment will be oral antihistamines. And the rash will be described as wheals. So an itchy red rash after upper respiratory tract infection or after stress or after exercise or after taking aspirin or opiates. Remember these two drugs, they are very important. Or soon after insect bite, then your diagnosis will be urticaria, and it will be managed as giving oral antihistamine, non-sedating specifically, such as cetirizine and loratadine. And if someone develop urticaria in pregnancy, then sedating antihistamines such as chlorpheniramine will be given. So a short summary of urticaria is that it is a skin rash with itchy bumps. The trigger, they include food, drugs, insect bite, skin contact with latex or metals, physical stimuli such as rubbing. Management includes cetirizine or loratadine, non-sedating antihistamines, calamine lotion can also be used, and in severe cases, oral prednisolone can also be used. There is one more differential diagnosis of urticaria, that is Lyme disease. Lyme disease is also caused by an insect bite, and urticaria can also be caused by an insect bite. So when will you say it's urticaria and when will you say it's Lyme disease? So if an itchy rash develop at the same day, then it will be urticaria. Again, the timing of the development of the rash is very important. After insect bite, if the person develop an itchy rash on the same day, then it will be urticaria and will give oral antihistamines. And if the rash appears 3 to 30 days after the insect bite, and the rash is annular rash or a target lesion, then it will be Lyme disease and will give oral doxycycline. So this was all about urticaria, its diagnosis and management. I hope it's clear, everyone.
So what's the difference between wheels and hives?
Difference between,
Wheels and hives.
they are almost same thing.
Right.
Wheal and flare, there is a difference between wheal and flare, but wheal and hive are almost the same thing. This redness, this is known as flare, and this uh, bumpy area or these patches, white itchy patches, they are known as wheal.
Mhm.
Any more questions?